Thank you. So basic mechanism of arrhythmia. This is patient with sinus rhythm. And then, as you can see, it develops a tachycardia. And the morphology of the P wave, if you look at lead V1, positive, negative, it changes, becomes a positive wave. So that distinctly, it is a different rhythm, but supraventricular rhythm, most likely an atrial tachycardia. And why did it happen? There can be enhanced automaticity of a focus. There's a focus which is dormant, like this is two action potential far apart, and you can make it faster for whatever reason. And I'm going to come to this. You remember that sinus node action potential that I showed is a little bit of sinusoidal wave. This is normal. If I make the threshold here, that means move it to negative, the action potential will come earlier and the rate will be faster. I can also change the threshold of this. I can make the whole thing up, decrease membrane diastolic potential, and that will reach the threshold faster. And I can do it like if I give sympathetic drug, adrenaline, this is what is going to happen. Or we can change the slope of this whole thing and make it faster. So look at this, what happens that this is the action potential of the sinus node. And if we give parasympathetic stimulation, the membrane threshold, resting membrane potential goes down. And it takes longer time to reach the threshold potential, and we get bradycardia. Reverse will happen if we give adrenaline, that it will move it up and we'll reach the threshold earlier. And so this is basically almost like physiological effect on automaticity, that I'm running, my heart rate goes up. But there can be pathological. So this is the example of physiological enhanced automaticity, a patient with sinus tachycardia with heart rate of 123 beats per minute. Now, what happened to this one? What kind of mechanism is this? We can have an abnormal enhanced automaticity, like supraventricular premature beat can happen because of enhanced automaticity, ventricular premature beat, lot of atrial tachycardia, and certain ventricular tachycardia, like RV outflow tract, VT, LV outflow, they can be of an automatic focus. And it's important to understand it because when you do ablation, we have to find the spot because it's automatic focus, and we can map it and we can ablate it. And if it is really an automatic tachycardia, it will basically, if we can pinpoint the location, we can ablate it. Now, how about this one? Anybody from the audience can tell me what this arrhythmia is? Can we get somebody to tell me what it is? Tushar?
Looking at those two strips.
No. I want from the participant, not you.
Okay. Sir, better you give choice because Dhriti Das, Dr. Dhriti Das, can you please tell? Kamral bhai, make her audible, please. Dr. Dhriti Das.
R1T phenomenon, toxicity point is.
Okay, that's great. But so what do you think is the mechanism?
R1T, early repolarization.
Okay. So your choice was R1T. Yes, that's an option because there is a T wave here and there is an R, and that produces arrhythmia. But it is also a long QT interval. So, thank you. So, what happens when we have long QT, we can develop early after depolarization, and that can produce arrhythmia. We can also get delayed after depolarization. These certain drugs can do it. This is another mechanism. And with long QT, it is early after depolarization. What happens when the QT is long? You can see this thing, and if this is big enough, it produces arrhythmia. Exactly that's what's happening with this, that look at this one, that this is happening. There is over here, there is one notch, nothing happened, but the next one big enough to produce this arrhythmia, and it stops. It starts and then stops. Why it starts that? Because it's changing the morphology, and it's a self-terminating arrhythmia, which almost looks like VR. So after depolarization is a mechanism, and it can be delayed or early after depolarization. And so it can be, this after depolarization can happen in phase 2, phase 3, and if it is in phase 4, that becomes delayed after depolarization. Interesting, look at this. This is calcium current dependent, and this is potassium current dependent. So it's fascinating that how two different kind of after depolarization early. One is calcium current dependent, one is potassium current dependent. And now the delayed after depolarization, early after depolarization is torsade, long QT arrhythmia, and delayed is a common example is digital toxicity, which produces the atrial tachycardia. This is the commonest one. And reperfusion arrhythmia is delayed after accelerated idioventricular rhythm after MIs and some form of, and the other one that is catecholaminergic polymorphic ventricular tachycardia, that is delayed after depolarization. And then, of course, the other mechanism that we get arrhythmia is reentry. This is reentry is the commonest arrhythmia. If we take a piece of tissue, this is the tissue, it's a hole inside, and if we put an electrical stimulation, it was initially done with jellyfish, early 1900, and you put an electrical stimulation here, it will go both ways. And then at the end, they will collide and extinguish. Nothing will happen because they're colliding with each other. However, if I put a pressure over here, that means I'm creating a block here, and then put the stimulus, the stimulation cannot go this way. Just a mechanical pressure can do it. And this is interesting. Look at this. They did it in early 1900 to prove this theory. And then once the electricity has started moving this way, it take it off. And once you take it off, there is an area of tissue which is excitable, and it can keep going round and round and round and round. And that's reentry until we stop it. Either it stops spontaneously or we stop it by some medication. This is an example of ventricular tachycardia, which most likely is reentrant tachycardia. I'm not going to go into details of this. Now, the reentry can happen because of an anatomical barrier. And what it means, let's say there is a myocardial tissue which gets infarcted here, and you can get reentry around it. Or you can have a functional barrier. What happens? Initially, there is a stimulus which enters this tissue and makes the whole tissue refractory and it acts like a dead tissue, and the reentry goes around it. And this is a functional barrier. And this is the example of scar-related ventricular tachycardia. So there is myocardial infarction-related scar, and the electricity can go around and then go through a slow connection and then exit, produce the QRS complex. And most of the drugs that we use, we target to make this place slow enough that it cannot conduct. Or if we do ablation, we will try to find the common area where the pathway is common and we ablate it. What happens? If I ablate it over here, the electricity will be going down this way and then continue working. So that's the tricky part of doing ablation in this patient, that you find this common exit point and ablate it. There can be other kind of reentry. It can be bundle bunch reentry, like this one. Electricity can go down through the right bundle, and then come back through the left bundle and produce a tachycardia, which looks like left bundle morphology, or other way. And we can see this kind of arrhythmia in patients with dilated cardiomyopathy. So the QRS complex will look like typical left bundle branch block, but it's actually a reentrant ventricular tachycardia. And the other form of reentry can happen in supraventricular arrhythmia, which is very, very common. And in Bangladesh, our focus should be these arrhythmias, because there are literally thousands of these patients in Bangladesh waiting to be ablated. And this is a cure. So it is important that we take care of this group of patients. So this is an arrhythmia. Can somebody tell me what this is?
Requesting other participants except Dhiti Das,
Yeah.
someone else, so we can broaden the horizon. We request participants to comment on this ECG. Already one participant has commented on the ECG earlier.
Tushar, anyone participant?
সেটাই বলছি।
Sudhir?
I request Dr. Naim Hassan. Dr. Naim Hassan, can you please tell the ECG?
Sir.
Understand?
And please
This is-
give your
What is this?
location,
Yeah.
then tell the ECG. আপনি কোত্থেকে এসেছেন যদি বলেন।
আমি ডক্টর নাইম রানীশঙ্কর উপজেলা হেলথ কমপ্লেক্স থেকে বলতেছি।
Oh, good. Thank you for joining us. Come on
Sir,
ahead.
ঠাকুরগা।
জি স্যার,
Okay.
জি স্যার, ঠাকুরগাঁও।
Come on
Sir,
ahead.
this is 12 lead surface ECG with proper lead placement. Here heart rate is around 280 beats per minute and regular narrow complex tachycardia. I don't see any distinct P wave, but there are not after the QRS complexes.
Mhm.
So my diagnosis, ECG diagnosis is this is supraventricular tachycardia, most likely AVNRT.
Oh, fantastic. So that's a wonderful. So the rate is not 280. I'll give you a simple way of doing it. So 2 boxes would have been 150.
Yes,
Little bit less than 2 weeks, so it would be like 170, 180 beats per minute.
yes,
But
sir, yes.
your observation is excellent. There is something after the QRS complex. And even if you could not see anything, the most like if you look at lead V3, you cannot see any P wave. But if you see lead V5, there is a notch. In V2, maybe there is something which normally you should not access. So this is AV node reentry. Absolutely. So AV node reentry, what happens is that there is slow pathway in the AV node and the fast pathway. Electricity can go down the slow pathway and then it blocks in the fast pathway, nothing happens, it takes a long period. But if the electricity goes down the slow pathway and come back to the fast pathway and the pathway is now open, it can go round and round. So it will come back through the fast pathway and go round the slow pathway slowly and come down to that. Because the AV node is in the middle, P and QRS complex is happening at the same time. And that's why you will not see the P wave. Or even if you see it, you will see either immediately before or immediately after the QRS complex. And that's the typical example of AV node reentry. Naim, thank you. So this is another one example of reentry. This is a narrow QRS tachycardia. If I imagine there is a P wave in the middle. So this is a patient with WPW syndrome. You can see clear pre-excitation. What happens with this arrhythmias? That electricity goes down through the AV node and comes back through the accessory pathway and then produce this narrow QRS tachycardia. So this is a macro reentry circuit. If it goes other way around, then you will get wide QRS. But because it is going down through the AV node, the QRS complex is going to be narrow. This is an example of atrial flutter. You can see the typical sawtooth appearance. What happens with atrial flutter? There is reentry in the right atrium. If you look at this inferior vena cava, and here is the tricuspid valve, imaginary tricuspid, there is a narrow corridor. And in that corridor, electricity can go down, and typical flutter is always going around this. Interestingly, we have mentioned this before. Typical flutter is not very common in Bangladesh. I do not know why, but in America is very common. European countries also very common. Also, I talk to doctors in Japan. They don't have that many flutter patients, but they have more fib. In Bangladesh, it's same. But if there is typical flutter, we can do ablation, and this is almost like a cure for typical atrial flutter. There can be another kind of re-entry. We see patients after cardiac surgery. If there is a scar in the right atrium, like if somebody went for atrial septal defect repair, they cut the right atrium to reach the atrial septum, and then there can be re-entry around it. And what the new surgeons do, they extend this incision to the atrioventricular junction. If we extend the incision to the atrioventricular junction, then there will be no gap and there will be no re-entry. So newer technique of surgeons, they will not do it this way. They will not leave a gap here. So this is another mechanism of, it's a macro re-entry. I think I'm going to stop here, and then we can discuss and go from there.
Sir?
Yeah.
Sir, as a mechanism, there is a term that is the Brady-dependent tachycardia or Brady-dependent VT. What is the mechanism, sir, really?
Oh, that's the bradycardia dependent is actually torsade most of the time. So if you look at
ওই আগের ইসিজিটা ছিল স্যার খুব সুন্দর।
This one. So what happens if you look at this QT interval? I don't have the previous R wave. There is a little bradycardia and this QT is longer. And this is actually triggering the torsade. That's why in torsade management, if we can get the heart rate up, look at this example. This one, let me just, there is a QRS and there is a normal QRS. QT is much shorter because the RR interval is short. This one, long RR interval, long QT interval, and that produces, this is actually perfect. This one did not produce the torsade because the QT is shorter here. It's just a PVC. So this is fantastic exam. Thanks for the question. So this is bradycardia dependent torsade. And that's why in patients who we give sotalol, we try to avoid significant bradycardia because then they can predispose them to torsade.
So, sir, this is basically direct after depolarization.
This is early after depolarization.
Sorry, early after depolarization.
Early after depolarization.
This brady-induced VT is because of the early EAD.
Early after, exactly.
Sir, is it the same, sir, the long pause, short pause can maybe the mechanism for the arrhythmia?
Oh, that is different. That long short sequence during electrophysiology study, that we do to create a gap in the conduction. So if there is a substrate which is slow conduction, fast conduction, sometimes we can use long short sequence to induce VT. That's just a technique to create a gap between the induction of tachycardia.
Now, I have one comment on that about the use dependency.
Sure.
And also it depends on the binding of the drug, whether it's higher heart rate or lower heart rate, okay? And the reverse use dependency in the sotalol type drug, they bind more when the heart rate is lower. That can cause prolonged QT and can cause EAD, early after depolarization. On the other hand, use dependency, there's like flecainide or class 1C drug, we call pocket the pill, when they bind better and even can terminate the tachyarrhythmia. So they work better when there's tachycardia. So, binding of the drug and higher heart rate, lower heart rate is also important in this type of situation.
All right, thank you. Any question from the audience, attendees? If not, then I think the talk should end here, and anybody wants to say anything.
What is LVOT VT?
Oh, LVOT VT, basically anatomically. So you can get ventricular tachycardia from the RV outflow tract, or you can get it from LV outflow tract. And most of these are automatic tachycardia. And they can be treated with medicine, beta blockers, or you can ablate them if you can map it. Yeah. And interestingly, a lot of the VT that we used to think of as RVOT are actually LVOT, because if you look at it, that RV outflow tract and the LV outflow, they sit very close to each other. And that's why the confusion happened. But now we have algorithm. If you look at the ECG, 12-bit ECG, from lead V1 to V6, and the leads are properly placed based on where the R wave transition is, you can more or less predict, is it an LVOT VT or RVOT VT? Thank you.
Sir?
Yeah.
Sir, we have got experience of some of the patients experiences very frequent torsades, sir, very frequent clinically in the ward or the CCU. We see there are some patients. Sir, what should be the actually appropriate medical management at that time? So very frequent torsades point is.
Oh, so the patient with very frequent, so you have to look at the electrolytes, number one. Number two, is there any offending drug? And the offending drug can be an antibiotic, because let's say the patient comes with sepsis and you start a new antibiotic, and that can be the cause. And then, of course, let's say somebody is already getting in and out of torsade. First of all, you stop the offending medication, try to keep the heart rate up. You give magnesium, even if the potassium is, magnesium is good, because that stabilizes the membrane. And those are there is no role of antiarrhythmic drug in this situation. And if you, the way to keep the heart rate up, you can give isoprenaline IV, or you can put a temporary pacemaker in, keep the heart rate up until the offending medication has washed off. And most of the time it will.
Thank you, sir.
And Rafique bhai, the one of the other trigger is the ischemia.
Yep.
And if we don't have any immediate cause, like drug-induced long QT or electrolyte imbalance, hypokalemia, hypomagnesemia, and the patient is not young and qualified to have CAD, then we need to be vigilant about ischemia triggering polymorphic VT.
Yes.
And in that case, anti-ischemia is the most powerful antiarrhythmic.
Sure.
But one thing, Rafique bhai, the LVOT or RVOT tachycardia, if we go back to the mechanism, then what will be the most likely mechanism in most of the VOT or RVOT tachycardia? VT.
Automatic focus.
Yeah, exactly.
Because when we do ablation, we do single. So what happens? Let's say there is a scar-related VT. We try to map the circuit, but in LVOT, RVOT VT, because it is automatic, it is coming from a specific point. We try to map it to that point and ablate, and it works. And the other thing that happens when you do the ablation, initially there is an acceleration of the VT, and that tells you that you are on the focus because it accelerates. So it's an automatic mechanism, and hence automaticity.
It's a very important issue in the board exam, because they also give the option for ICD, which is the answer. It has their choice is the ablation.
Sir.
Thank you very much, sir. And though it's quite a long gap, but again, we're rejuvenated by the excellent lectures from Professor Rafique Ahmed, sir. And I'd like to request Dr. Abdul Wahid Chaudhary, sir, to say his remarks on this lecture and conclude the session. Wahid, sir.
Hello.
Hey, Badul bhai.
Eh,
We can listen.
স্যার এটা অফ করে দিবেন
Yes.
আমার মনে হয় যে স্যার যেটা প্রপোজ করেছিলেন এবং দেখিয়েছেন যে আমাদের কিন্তু এই যে বেসিকটা কেন হচ্ছে কি হচ্ছে, আমরা যে ওষুধগুলো ব্যবহার করছি কোন জায়গাটা কি কারণে ব্যবহার করছি, এই আন্ডারস্ট্যান্ডিংটা আমাদের কিন্তু আস্তে আস্তে ক্লিয়ার হওয়া উচিত। এবং যেহেতু এরিথমিয়া এমন একটা জিনিস এবং এখন যেহেতু একদম টার্গেটেড থেরাপির জন্য ওষুধ তৈরি হচ্ছে, আমাদের এই সেলুলার মেকানিজম গুলো আন্ডারস্ট্যান্ডিং করাটা সময় চলে আসছে। এক সময় ছিল এত জরুরি ছিল না, এখন কিন্তু সেটা আমাদের বুঝতে হবে যে কোন জায়গাটা কি ওষুধ কেন দিচ্ছি এবং কি প্রবলেম হতে পারে। এই যে আরেকটা যেটা দেখুন কথা শেষের দিকে এসেছিল যে এরিথমিয়ার ক্ষেত্রে খুব একটা ইম্পর্টেন্ট জিনিস হলো ড্রাগ ইন্টারাকশন, এবং সেক্ষেত্রে ইলেকট্রোলাইটে কি রোল আছে আমার মনে হয় এর পরবর্তী লেকচারগুলো যখন আরো স্যার যাবেন তখন কিন্তু দেখাবেন কোন ইলেকট্রোলাইটের ঘাটতি বা বেশি থাকার কারণে কি ধরনের প্রবলেম হতে পারে, আবারও সেই সেলুলার মেকানিজমের কথাটাই আসবে। এবং সেক্ষেত্রে কোন ধরনের ওষুধটা তাকে ভালো কাজ করবে আমাদের কিন্তু সেটাও ওখান থেকে আমরা আন্দাজ করতে পারবো। কাজে ব্লাইন্ডলি একটা ওষুধ দেব, এখন কিন্তু এরিথমিয়া ট্রিটমেন্টে সেই জিনিসটা কিন্তু গ্র্যাজুয়ালি উঠে যাচ্ছে। আমাদের কিছু কিছু জিনিস সবসময় মুখস্থ করতে হয়, ইমার্জেন্সিতে আমরা ড্রাগ এটা ইউজ করবো ব্রড স্পেকট্রাম অ্যান্টি এরিথমিক, কিন্তু এরপরে এই টার্গেটেড থেরাপির ব্যাপারটা আমাদেরকে আরো বেশি সচেতন হওয়া দরকার। স্যার আজকে এটা সূত্রপাত করলেন, আশা করি আমরা কিন্তু আরো শিখবো এইভাবে। স্যারকে অনেক ধন্যবাদ এই জন্য।
Thank you.